I'm so used to people having a hard time finding the 7th floor, but I'm really pleased that so many of you made it up here so quickly. I'm Jan Kasperski, and in my professional life, I'm the CEO of the Ontario Psychological Association. In my personal life, I have had a very long and interesting career. There are not too many people who can say that they have been in the healthcare system for 50 years and actually predate OHIP. My husband quite often will say that I have never slept around, but I sure have worked around. And I have had the pleasure of working in many organizations, been on many, many boards, and have had a pretty enriched life. But throughout most of my career, trying to find ways of being able to improve the life of those that are most vulnerable has been a key mission for me. And at one point, I did have the Autism Consultative Service down in Niagara, along with the Child Developmental Program there as part of a senior VP position. So while I wasn't a hands-on, I certainly had an opportunity to really see what the care level was like at that point in time. And autism was, at that particular point in time, a disorder in which many parents were given the option of suffering terribly with trying to deal with the most complex of children, or making a decision to put them in group homes. Those that were on the spectrum disorder were simply not labeled at all, did not get any level of care. And there was a very strong feeling during that period of time of don't label what you can't treat. And so we have a cohort of young people who were never given any support and are heading towards adulthood. We have another cohort who were diagnosed, were given opportunities for at least some treatments, and thanks to a lot of advocacy on the part, mostly of parents, it became very important for diagnosis in order to get treatment. And again, that's the group that are really starting to hit the transition period. We are going to walk through, as an interprofessional team, how today we would really like to see the care that should be delivered to anyone who has a child with a developmental type of disorder. There are two of us on the panel who not only have professional interests in this particular arena, but are kind of living with, as parents, the issues that all parents deal with. And that's Fern, who is the expert nurse on our panel, and myself. And while I'm going to walk you through a case study that is very important to me, because this is an actual presentation of a family friend. He's not quite that age at this point in time, and I'll explain why. But I also want to tell you about my grandson. So I was a very young mom. I went in nursing when I was 16, and by the time I was 19, I had my first child, and raised 3 kids before I was 21. When my middle child was unable to look after dear Ryan, our grandson, my husband and I adopted him at 5 weeks of age, and he's been our poster child. They asked me at one point in time, what's the difference in looking after a child when you're in your 50s versus your 20s? And I laughingly said, once you get down to play, you can't get up. So, always have a chair by your side. He was a golden child. He was super in sports. At one point, he was planning to go pro. He was scouted down in the States and over in Manchester. And he was our poster child for mild traumatic brain injuries. So we were in 3 different emerge departments while he was having his minor brain injuries. And we practiced how to deal with minor trauma. And it was very, very helpful because the weekend before he was heading off to university, with a plan to become a lawyer and then the medical officer of health, he had actually spent a day as your minister of health. He was T-boned by a dump truck and had a catastrophic brain injury. But because that child was injured in a car, he has up to $1 million worth of insurance or more, and the most incredible team. And what you will see today is the type of team approach that has allowed Ryan, within 3 months of his catastrophic brain injury, to start university. And while Ryan is not the person that he was or the person that he would have been, he is an absolutely amazing person in struggling and moving forward with great optimism, thanks to the team. So this interprofessional team is very important to me in being able to really present to you how every child, every young adult, and every adult, the case that we're going to talk about, should have in terms of the care delivery system. So I'm going to read you a little bit about the case we've studied. So I had presented a case in which we were looking at transitions, but the team decided that we would age Brian to a 62-year-old male. And he is now in the emerge department of the waiting room at a very large academic health science center. His mother has been brought from their community to that academic center because of stroke management program that is there. It took them a while to get there, so she is not getting the benefit of the acute stroke program that would have been there for her with TPA. So things are not looking very good for her in terms of her prognosis. And he was the one who found her. And he's very, very distressed. He's in the waiting room. He's jumping up and down. He's waving his arms frantically. He's humming out loud. And the rest of the patients are very, very disturbed by him. The triage nurse was trying to get some information about him. A neighbor did bring him to the hospital. She doesn't really know him too well. She hasn't met him very often. He seems to hide whenever she comes to the house, but she has a really good relationship with the mother, and she's heard a lot of stories about Brian. And the mother had told a story to this neighbor about Ryan when he was 10, and his class was taken on a field trip. And the teachers had arranged for the class to play soccer at the local school. And as per usual, he was picked last. And every one of the kids on the team who ended up with him as part of their team were groaning out loud. And the ball, as they started to play, came flying at him. And he started to run down the field. And as usual, he tripped on the ball and he fell to the ground. And he started crying. And the kids started chanting, "Cry baby, cry baby." And then they started mimicking the funny way that he runs. Well, he ran away, and he was found sitting in the middle of a very busy road in a strange town. And a truck driver stopped and picked him up off the road. And he was completely mute. He wouldn't tell his name or where he lived. So the truck driver took him to the police station. Luckily, he was wearing a T-shirt with the school name and town on it. So the police called the school, and in turn the school called the teachers that were looking after these children, and in turn they got in contact with the parents. He was brought home, and he was hospitalized for 3 months, and the doctors gave him a variety of medications at that time, but nothing really seemed to work. And his first words were to a classmate, and that was Ryan, who tried to protect him from the other children, and oftentimes got bullied and ostracized as well for being a friend to this young boy. That's my Ryan. By the time Brian finished high school, he had completed 2 years of university, and he was admitted to the undergrad program in nuclear physics and engineering. While he was at university, he was found in an alley, and there were obvious signs that he'd been beaten. And he was mute for about a year at that time. And in spite of not communicating verbally to anyone, he completed most of the coursework, not only for his undergrad, but for his master's degree, and he went straight into a PhD program. And he was 20 by the time he finished his master's degree, and 24 by the time he had his PhD. How many of us are still working on it? He has been working in the same lab since that time, and he's been living at home with his mother. His father died of a heart attack while he was still at university, and if you really look at a lot of the stories, the family breakup is quite predominant, and quite often it's mothers left with these young people. His mother had learned to keep him calm and functioning by making certain that his daily routines were not changed. She packed his lunch every day and made sure that he had exactly the same thing in his bag every day. And she alternated fish and chicken for dinner every night and make sure that he had tea and toast at exactly 8:30 p.m. He complained about his clothes, and he would only wear sweatpants and T-shirts to work, and it always had to be light blue. And he had a friend when he started at the lab, but he left, and he's not been able to socialize with anyone ever since. Now, this is the story, but we're now in an emerge department with this young man out of control in the waiting room. And the team is going to take you through the scenario that nursing and the rest of the team would use in an emerge in order to deal with the immediacy of a 62-year-old man who, with that kind of history, is now in the emerge department. And I'm going to invite Fern Quint, who's our registered nurse crisis intervention person, to come to the podium and really talk about what nursing would do in this situation. And on the screen behind you, the group is really going to look at a biopsychosocial case conceptualization matrix and try and walk you through how each of the disciplines will really try to fit within the work that they do in those boxes, as it were. But knowing the population that we're dealing with, working within boxes is not going to be the approach that this team is going to take. So you will see some very interesting ways in which each of the disciplines is going to handle this case. And when the team has had a chance to talk about what they perceive they will do, we really want to engage all of you in what it's like in your arenas for being able to deal with patients like this, particularly if you've been able to work towards interprofessional teamwork. So Fern, who's the other parent expert along with her professional hat.
So right now we're in the emergency room, and I'm going to intertwine the roles of two different types of nurses. One is the triage nurse, and the second would be the crisis nurse that's called from the mental health team. So I've done a very brief view of the conceptualization, basically because emerge is fast-paced. It's the pushes, get them out of there, no matter what people say, treating out. And there's more of a focus now on family and patient-centered care, but there never used to be, so we're lucky to have that now. So the role of the emergency nurse is to triage, assess, coordinate care, and initiate consults that'll come down. So in terms of the biological presenting factors, in the emergency room, just simplistically, we don't know whether Brian's needs are going to be met anymore or whether he can care for himself because his mother is very sick. In terms of the precipitating factors, again, that falls under the same thing. So we have no idea what we're going to be sending him home to. And his protective factors is that he has no identified health problems on a cursory look. Psychologically, he's presenting, he's out of his routine. It's really hard for him. The sensory overload in Emerge is unbelievable. The noises, the action, nothing's staying still. People are coming in and out. Lights are flashing. Security might be running. There could be a code. No one, you hear the announcements overhead. It's a really wild environment and can be. And there's Brian jumping up and down and waving his arms and humming, so we can see that he's in trauma. And in terms of his precipitating is his history of trauma and bullying, his fear and confusion. And the protective factor would be that he is able to function. We know he works and he's able to function within a limited structure and routine. In terms of the social, there's no social friends or contacts. It's just that one neighbor. And again, with the protective factors that he's been able to maintain his employment. So we look at it, sorry about that. Whoops, I don't, okay. We looked at it in a very simplistic level. How do I get this back up? Okay. So in dealing, thank you. Can't put my hands on the computer. Sorry, oops.
I'm as useless as.
Okay, I'll keep going in the meantime.
Doing this.
Yeah, I was, okay, great, thank you. So first, the Emerge nurse has to tend to his immediate needs, and it's important to be sure he's registered in Emerge if he can be seen, and then we'll hopefully, between the Emerge nurse and calling down a crisis nurse for psychiatric assessment. And so I would come down as the crisis nurse now, and the first thing would be is to look at the location where Brian is. He's in the waiting room. We've got to get him into a quiet room to de-escalate and take him away from all the sensory overload. And we need to take time to allow him to feel safe in this strange environment where he's already scared to death about losing his mom. And his feelings are that he's desolate and probably and really quite frightened. So once we find a quiet room, then the assessment would start. And it's important to start right away to build a relationship with him, to be honest and authentic. We have to take, I think on some level, take the professional veneer away. I've certainly seen that being as a mother of a son who's now doing extremely well. It's very interesting to be on both sides of the fence and see how I was treated and my son was treated during different times. So it's something I'm very cognizant of. And it's important to be authentic, be real, and show that you really do care. And if it's not a good time, it's better to go for a coffee before you do the assessment and make sure you go in there really ready to do it. To build that rapport, we have to give Brian enough time to express his concerns, his fears, his thoughts. Active listening is imperative. He needs to know that he's been heard and his concerns will be addressed. And we have to keep our language clear, our words concise and simple, and be compassionate. But we also have to make sure that we let him know the clear expectations regarding his behavior, that he can't be flapping around Emerge. It doesn't work. So we have to tell him and let him know and help him to set some controls for that. So we know you're really upset. What will help you calm down? And the best thing that I've found is to ask people on the spectrum, tell me what you need right now. What is it that you use to calm down at home? What can I do for you to make it easier? While setting expectations. So if you feel that you want to pace in this room where it's not going to disturb anyone, pace away if that helps you calm down, but it can't happen in the waiting area of Emerge. And that's up to us as professionals to ensure that he has an environment to allow him to do that. And one of the things that I think we tend to forget in the Emerge is people often haven't eaten. So he may be hungry, and his blood sugar might be low, so it's important to bring a snack and hopefully to ask him what he likes. Hopefully they'll have something in the hospital. If not, I would send that neighbor out to the nearest restaurant and pick him up some food that can tide him over for a while. And then after I've done the assessment, I would assess the need for psychiatric intervention. If he can't calm down, he would need to see a psychiatrist, particularly with the focus on immediate medication at that time. And we need to look at different other ways that we can decrease and de-escalate his behavior, and to find out as well, is he already on medications? As part of the assessment as well, we would include a suicide risk and what his normal coping skills are that help him the best on a day-to-day basis. Given his mother's guarded prognosis, one of the things that I have done in our emergency department is to call the chaplaincy department. And they'll come in on call, they'll come in every hour, at any hour rather, to help the individual cope with the impending loss, if that's what's going to happen, of his family member. Additionally, there's other supports that can be brought into the emergency room. There's the mobile crisis team that will come in. They have transitional workers, and the crisis nurse calls them to bring them in, and we get a transitional worker to provide short-term case management, which goes about 6 weeks, and can be with Brian on a day-to-day basis outside. As well, we would initiate a social work referral from Emerge to deal with to deal with what's going to happen in the community and for assistance planning. And then at one point, if he can't rest in the Emerge, maybe there's a way that we could send him home to get some rest with some support in his comfortable environment. So that's just highlighting the initial part, and I'm going to turn it over to David.
Thanks, Fern. It's so wonderful to work in a team. I remember when I was growing up, there was a joke saying how many people it takes to change a light bulbs, and they know I'm not a very handy person, so all my friends said, well, probably 5 to 7. and in a way, dealing with this case really optimally takes more than a few people. And for a psychiatrist, the role really are two-pronged. First is the acute phase, and then the subacute phase. The first phase may last for hours. And usually it's not so linear, like after Fern leaves, then, okay, I'll walk in. Especially for someone with autism, they feel so much more comfortable if there is that sameness. So often I bring in the nurse who has already established the rapport in a quiet sensory room, hopefully amidst the busy emergency department. There's a place where there's no fluorescent light, because often that bothers them. And so it does take a lot longer. I may sit there while Fern continues to pick up where she left off, and then we slowly to help escalate the situation. Remembering he was flailing his hands, he may not even be responsive to verbal redirections. And so if he's able to settle down somewhat, then I start do the risk assessment. Otherwise, medication would be necessary. And always keeping the principle in mind, starting slow and starting little. And so we used to use benzodiazepines as the first line, but I'm not going to go into details because there are a couple of workshops actually, even including this afternoon, who will cover what medications would be most suitable and the algorithm that has been used as a guide. And so usually the assessment takes place over a number of hours. And the reason why is when a person comes in in such a crisis state, the escalation and stabilization, as well as risk assessment, may take place in a continuum. The risk assessment takes 3 forms. Number one, immediate safety concerns to others and to the person, himself in this case, as well as physical impairment. What happens if the person settles down and goes home? He has been relying on the mom for all type of supports, and so is the person able to do that? And how do we assess that, assuming that Brian can calm down? One of them is observing his ability to do the activities of daily living for that evening even. And also, how can he come back to the community center or the team for follow-up? As well as in terms of the competency to seek help. Like if he really does not feel well overnight after discharge, can he call 911 or reach somebody to access even the crisis team? So assuming that the crisis intervention is done and is successful to calm him down, then medical workup is very important. Reading the history, we know he had possibly had trauma, like he stayed in hospital for 3 months, like that's significant. So what happened to that? Any residual cognitive impairments, even though he's very bright, has been working the lab with no problem, certainly that needs to be done. So perhaps some of the imaging studies, and then if he's ready to go, discharge planning that would certainly be necessary. And from the legal perspective, are there any advance directives maybe from the mom? Like who is going to look after him when she is not well? Or power of attorney, that type of things we need to be sorted out. But fortunate enough, we have the whole team here with multiple disciplines, so I often rely on the other members of the team to look into that. But smaller centers, certainly those things need to be addressed as part of my acute phase kind of intervention. Then moving on to the subacute phase, which means once he's in the community, there is an ongoing assessment about the risks. And one of those ongoing risks would be self-harm. It has been shown that 66% of the higher functioning Asperger's or autistic individuals have contemplated suicide in their lifetime. And 35% actually have made active plans or even attempt to end their lives. And so those with depression especially are 4 times as likely to have suicidal ideation and twice as likely to attempt to end their lives. So obviously it is a significant risk. But the good news is that suicidal attempt is rarely made after an impulsive decision or following a so-called sudden crisis if there is no history of prior attempt or existing depression. And so if Brian never had that and he calmed down and able to tell me what he would do this evening as well as the following day, how to contact the crisis team and get back for follow-up, I would be comfortable letting him go after medical clearance. And then in terms of the other type of assessment in the community, obviously there is a big overlap. And with the team, I would defer to the psychologist who would do a full psychological kind of profile, as well as looking into past histories, such as any OT involvement, speech involvement, as well as maybe genetic testing and also imaging studies. Truly, have there been any brain injuries that are still kind of lingering? And also, we know that ASD individuals, they may be higher functioning in particular areas. They often neglect their own personal health. And so there may be some silent chronic conditions such as diabetes, thyroid problems that have not been addressed. And so that certainly need to be followed as well. And so having said that, I think I would refer to our next member of the team, the social worker, always come to my rescue.
Now, I did a really poor job of introducing the panel members, but in your package is the bios for each one of them. And at this point, this is Noelle. And Noelle is our social worker who's been brought into the Emerge department to coordinate the discharge.
Hello, everybody. My name is Noela, and I am a social worker with the Center for Addiction and Mental Health. So given the framework of this individual, we always want to work from a biopsychosocial holistic model to best support this individual. Biologically, we know the age of the individual is 62, as well as the age of the mother. So when I approach a situation like this, I want to look at the family situation, I want to look at the individual situation, as well as community supports. So we know that his mother is in hospital, stroke, and we know that he has past trauma history when it comes to being bullied, as well as the physical abuse that he did suffer early on in life, as well as the death of his father. Presenting factors, his mom was his primary support. She may or may not be able to care for him at this time, so we need to look for other supports within the community. We do know that some of his strengths is that this individual is very insightful. He was able to finish school, go through school, hold a PhD, hold a job. We also know that even though he does have some lack of social interactions with other people, he did have a friend who is now not in the picture. So we want to take all of that into consideration. With the death of his father, maybe there were some coping strategies that he did utilize. So we want to look upon that as well, pending the outcome of his mother. My role within this framework, one would be look at discharge planning or transitional planning, not only for the individual, but his mother. Oftentimes, the individuals that we do care for with ASD, the family is the primary caregiver. And when the family is not able to provide that support, we look to extended family or what supports in the community can best support him given his needs. We also want to look at planning for the mother. So given her prognosis, is she going to need supports within the home or in the community as well? And because of the death of his father and the prognosis of his mother, is there any other family members? And if there's not any other family members, what supports in the community would be best for him? So to ensure that I take the direction and look for the best community supports, I would look to the interprofessional team of the psychology to kind of assess the past trauma history that the client does face, and is this a barrier in terms of the coping or any sensory needs, and even the speech and language. We know that when he did have that past trauma history, he kind of went mute for a while. So can the speech and language come in and try and assess him? After all those assessments are done, I use their recommendations and their outcomes to best look for the most appropriate community supports for this individual. So is this a group home? Does a group home match his behavioral needs? Does a group home or day program or respite worker match his sensory needs or the language needs? So I look to the team to kind of direct based on the community supports. And we also want to keep in mind just making sure that the mother is taken care of as well. And there are supports put in place for her, whether they're in-home supports or in terms of a long care facility that she may need to go to. And I think that is it. So I will call on the psychologist to come in.
Good morning. My name is Susan Ferrell, and I'm a clinical psychologist with dual diagnosis and community-based teams in Ottawa. So I bring a bit of a different perspective because I'm not typically in Emerge, but hopefully involved in Brian's life. I also bring the out-of-town perspective to the table, and I feel like listening to your weather this morning, I should bring the apology that I've clearly brought some Ottawa weather. You had a lot of announcements of extreme cold weather warning this morning, whereas I listened to your temperatures and thought, oh good, I don't need a hat today. So it's all relative. What's important in thinking a little bit about this is also what's relative in Brian's life to the contributions of different disciplines and at different times. The good news in this situation is that Brian won't be in Emerge forever. The bad news is figuring out how we mobilize what's needed there to extend past for him. So what's the plan going forward? As I mentioned, it's not very often that clinical psychologists are in Emerge, but therefore it's not often remembered how we might be useful in the care planning for Brian going forward. This panel is a wonderful illustration of the fact that we don't do it alone. No discipline can do it alone, and that's already been spoken to. But there's the immediacy of his needs and then some of the longer-term planning. People have already spoken well to some of the current presenting factors, the precipitating things or things that may have come before, and even touched a bit on the protecting factors. How is it that we, perhaps as a mental health system, haven't met Brian until this point? But now he's here and he's with us, and the important point is going forward. What is it that we can contribute? One of the things that's particularly important in planning forward for people, but often forgotten in publicly funded adult-based services, is fully understanding someone's cognitive profile, particularly at times after they have left the school system. If someone is fortunate in the school system, they've had their cognitive profile looked at and assessed as they develop. By that I mean how they think, learn, remember, how their executive functioning skills such as problem solving, planning, ordering things, how those things fit together and give a unique picture. Each of us have a very different cognitive profile from one another, and Brian's is different again, but perhaps not well understood. It's really important to see where he has been able to hold a job that I hope has been rewarding for him, have some level of engagement in a university campus, perhaps, but perhaps in other dimensions, not at all. And so one of the things to offer going forward for Brian is as his mom's situation changes, and Noela and others speak well to the idea of where will his life take and where will mom be placed, what is it about Brian and his cognitive profile and his diagnostic or mental health profile that's going to really matter in terms of how he interacts with this world going forward? So long outside of the immediacy of an emergency room crisis, there's an opportunity to look at Brian's cognitive profile, to look, as the first speaker this morning said, talk at the great areas of strength, but look at places in his social and adaptive functioning, maybe his memory functioning or other coping skills where he may be quite challenged. Areas that can be very amenable to skill-based learning if we understand them. But often we see a person and assume that a skill in one area means high skills in others. This room doesn't need to be told that, in fact, we're all much more like a patchwork quilt and need to understand that much better for him. It's also been spoken about what is there a role for past trauma related to what had happened to him when younger, or even thinking about social interactions? Have people misunderstood this as social anxiety, nervousness, shyness, or other things, social avoidance? Lots of labels come with things that may or may not be remotely helpful. But importantly, what does Brian think about suddenly interfacing with the service system? So here we are, and we all seem pretty keen to help, but he didn't really ask for any of us. So how do we get into his life in a way that can be helpful? So cognitive assessments, what we call psychodiagnostic or mental health assessments, can really work to then inform the important interventions of a lot of my colleagues. And you're going to hear from OT, behavior therapy, and speech about some of those important things. The other thing is about the future interactions with the service system. So a crisis has brought Brian into our life right now, but there may be other times that he's going to be interacting in the future, perhaps without the benefit of his mother or other people who might know him well. So looking at planning forward, how do we take what we know about his cognition and his mental health and plan that forward? Websites like DD Cares, the initiative with Yona Lensky out of CAMH, have done a good job using things like health passports and planning out how do we know something about Brian so that when he does have to interface with other parts of the healthcare system, he's best understood. And depending on consent, what is it that the people at the university know about Brian? Is Brian 3 years from sort of the traditional age of retirement? And what's that going to mean? What does work-life balance mean for Brian? What do things like retirement, which is a key transition for most people, mean? And how is that going to affect his life, but also the aging process, both for his brain and his social interactions? So the running joke about psychologists is we just ask a lot of questions. We also try to hope to provide some answers. Those are the key questions that we'd be asking in Brian's life and working together with the team to come up with answers. Thank you.
Hi, my name is Erin Lymer. I'm the occupational therapist on the outpatient dual diagnosis service at CAMH. And just to pick up from where psychology left off, the OT can really serve two roles. So we can work within the hospital in an inpatient setting, and we can also be very much out in the community doing some of those follow-up pieces. So just to go through some of the biological, psychological, and social concerns that would be pertinent specifically to OT, a lot of them have already been touched on. In terms of biological presenting factors, things that would stand out to me immediately working in the ED setting upon meeting Brian, would be his obvious signs of sensory dysregulation and distress. So that's where I would probably step in. I'd maybe work with Fern, look at some ways that I might be able to help. Some EDs, the ED at CAMH in particular, has a sensory calming kit available. So they've already mentioned moving him out of fluorescent lights that could be triggering for him, moving him away from crowds, moving him away from, alarms that might be going off, getting him into a more darkened, comfortable environment. As the OT, I'd probably sit in with Dr. Ng and Fern just to kind of observe. Maybe I can give him a hand fidget, something that he can hold, something to help regulate him, making sure he has comfortable seating, meeting all of those other kind of biological needs around whether he's thirsty, whether he's eaten, those kinds of considerations. By reviewing his history, I'd also have indications that sensory aversions and specific preferences are probably impacting his daily life and routines. So always wearing the same kinds of clothing, preferring certain colors, those kinds of things. In terms of precipitating factors, so we do have likely these underlying sensory processing differences. And in terms of biological protective factors, with respect to his sensory processing differences, he's probably already developed some ability to cope or to regulate himself. So we're meeting him in a moment where he's highly dysregulated. There's a lot of emotional stress. There's a lot of sensory triggers in this environment that's probably unfamiliar to him. And so he's using some of the strategies that he knows will help to calm him down a little bit or help to regulate him a little bit. But beyond that, on a day-to-day basis, he's probably already figured out a lot of things that are helpful to him. Other protective factors are that he appears to be of above average intelligence, so when I'm working with him longer term in the community, he'll probably be able to give me some information about what his sensory preferences are, what's aversive to him, and how he likes to structure his day, his routine, and his choices. So other things to note in terms of psychological factors are that his level of independence for presenting factors is very, very unclear. I think Dr. Volkmar made a great point when he was saying don't assume anything, and I think as the occupational therapist going into this, I wouldn't want to assume anything about his ADL or instrumental activity daily living skills. So I don't know whether his mom has been reminding him to shower his whole life or to wash his hair or doing all of his laundry for him. So these are all things that I don't know. They're all question marks. She had been doing a lot of it, so she was a large protective factor. But his high intelligence would probably be definite asset in terms of learning skills or where there may be gaps, filling in those voids pretty quickly. Social presenting factors, so we're presuming that he may not have a lot of meaningful relationships in his life right now, and especially now that his mother's become ill. We don't know of any other friendships or anything along those lines. Also, his repertoire of leisure activities seems to be very limited. We're not aware of any existing at all. And that's a concern because we spoke already about pending retirement. So what is his day going to look like, and how would a loss of a daily structure that he's had for almost 40 years impact his mental health? And And he may have very specific interests and strengths. We know that he has a background in engineering and physics. That could be a protective factor. Socially, could we use that to leverage new interests, new friendships, online relationships, trips to museums, whatever? Is that something that I would be able to leverage long term to kind of engage in a relationship with him, build a rapport with him, take him into the community and those kinds of things? So after he's left the hospital and he's gone home, if he has gone to his own home, again, I wouldn't want to assume anything, so maybe that neighbor would be helpful in checking in with him once he's gone home. Does he have food in the fridge? We're not going to assume that he would just call for fast food. If his mom's been making his meals, calling for fast food might be something that's really overwhelming for him. He may be like the person who goes into McDonald's and gets thrown off by the fajita. We don't know. So it'd be really important to mobilize neighbors, extended family, all of those kinds of things to make sure that everything can remain as consistent and as familiar in that immediate time period. If he's going to someone else's house or some kind of interim crisis support, what can we do to keep that really consistent? So can we make sure that he's having chicken or fish for dinner? Can we keep things as routine, as predictable? Can we bring all of his clothes over to him? Is there any kind of music that he really enjoyed? Is there a quiet room in the house that he's going to be staying in that he can be kind of welcome to bring his stuff into and kind of make his own? So what can we do to keep everything comfortable, familiar, structured, and safe for him in this kind of crisis period? And that's something that if there is an interim case manager, then the OT and the BT would probably work really closely with them to help establish that. In the longer term, that's kind of where I would look a lot more closely at all of those functional skills. So in terms of all of his self-care abilities, his productive skills and his leisure skills. So in terms of immediate self-care, again, what are his routines around being able to take care of himself and maintain his personal hygiene? What does his dental health look like? He may have the ability to perform these things when I ask him to do it for me and I observe it, but was his mom cueing him to do a lot of it? That would be a big question for me. And how is he going to remember to do it now that no one's reminding him? Does he know how many times a week he should be doing it? So those are things that I would ask in terms of self-care. And then in terms of his instrumental activities of daily living, what's going on with his bank account? Was his mom managing his finances for him? Does he know how to use a debit card? Does he have an RRSP? What would that look like for him? Does he know how to make a budget for himself? Does he know how to figure out what his expenses are going to be in the long term? So those are really concrete skills does he know how to fill out a check? Those are all really specific things that I would want to look at. Even make change. Does he know how to do that? Has he maybe just been relying really heavily on that tap debit card, and when he's gone out with his mom, everything has been paid for him? Has he really been in a setting where his routine has changed, so he's had to buy something on the spot, or has mom been purchasing bus tickets for him his entire life? So these are really important questions that we just can't assume. We have to look at those things. And then in terms of his kind of productive in his work life, has he been driving to work? Has he been taking the TTC? How would that change? What are his leisure interests? So I might do a leisure profile for him and find out what kinds of things can we start engaging him in right now. And that would be a great rapport building activity. So we can start with those specific things that he's really interested in and try to extend it out and try to use outings in the community and visits to the home and observational sessions as kind of opportunities to also gain information about his sensory processing. So aversions and preferences and how we can structure his new life and his new routine to meet his needs. I'd also get information about sensory processing from having him fill out more structured measurements like the adolescent adult sensory profile. That would give me really specific information. And because he probably has some insight into that and he is higher functioning, he'd be a great candidate for a pencil and paper type of assessment like that. And then we'd also use these interactions and outings as kind of a naturalistic way to talk to him about what he would do when he's feeling escalated and work on emotional regulation and coping strategies and bringing sensory strategies into his daily life and when he needs to take a break or when he might need to do deep breathing or when he might need to listen to certain types of music to calm himself down. And then we could build that up in terms of a crisis management plan, so kind of low-lying levels of agitation to higher levels of agitation, looking at who he might call, who he might want to talk to, crisis lines, mobile crisis units, all the way up. And I would work really closely on that with the behavior therapist as well. So yeah, kind of skills teaching, going out, getting to know him. We could also use that as opportunities to work on social skills and make some of those concrete rules for him and lay it out for him, whether that's in a book or something that he keeps on his phone when he's entering a new situation that he can pull up and search for the rule that applies when he goes to McDonald's or the rule that applies when he goes grocery shopping. So that would be the OT piece, really, just taking a really close look at what his day-to-day life is going to look like and how we can support him in filling in some of those voids that maybe his mom was filling in for him, and also encouraging him to branch out a little bit and maybe try some new things and build some more meaningful occupation into his day-to-day life.
Hi everyone, my name is Olivia Shaw and I'm a board certified behavior analyst and specifically work at CAMH in the outpatient program in our dual, actually now called adult neurodevelopmental program. I want to take this time just to pause a little bit on Brian and just speak a little bit more to what behavior therapy is, because I think it's often not a traditional part of a hospital team, let's say, in that emerge department, and more in the community, I'd say we would be relevant there. So again, behavior therapy uses the principles of applied behavioral analysis to assess the relationship between that observable behavior and the environment, and what was happening before that could be making the context for that behavior to show up, and then what is the outcome of it, what's the consequence following that presentation. And applied behavioral analysis really focuses on systematically applying evidence-based interventions with the principles of learning to improve socially significant behaviors. So again, really understanding what's meaningful for this individual and their supports and their circle of care, and what changes to that behavior that could have the biggest impact to the whole system. And again, just more background information. Education, specifically in applied behavioral analysis, is within Canada and within Ontario. And again, people have pretty well a combination of education and experience from the PhD level all the way to college diploma. Again, certification is up and coming. It's through the States right now. Canada is still catching up, but there is a movement towards provincial professional regulation within the field. Okay, now back to Brian. So one of the biggest priorities, I think, for Brian in terms of the biological presenting category there would be that we want to just have a look, if I can get into the ER, if I'm present that day, looking at that jumping, that waving, the humming, that kind of presentation, that sort of distress presentation, and figuring out whether there is a need for a full functional behavioral assessment. And again, the nature of that usually can focus on a behavioral excess. So we know in ASD it could be restrictive and repetitive behaviors, or self-injurious behavior possibly, as well as some of the deficits. So the communication skills, the deficits in social skills. We're going to want to see once he can get settled, and maybe this may happen more within the community setting once he is settled in whatever transitional phase and location that he ends up in. We want to talk to him. We want to get him in a really calm, comfortable space within his preferences, within his routines, to help identify what he needs, and what does that presentation of the jumping, the waving, the humming, what kind of purpose does that serve for him? And whether he would like any support in learning some more discrete other coping skills to expand that. And again, the focus of that assessment would be understanding the purpose of that and what function it serves for him. And again, along with my team, I'm going to want to identify and defer to my team to make sure that the mental health, any mental health concerns or psychiatric concerns are being met in that regard as well. Since Brian does have some insights, we're going to talk to him about building that crisis plan that Erin did introduce. And I'd work closely with Erin on that and creating a safety plan as well. So when he's feeling certain ways, when he's feeling hot and he's feeling flush and his heart is racing, you can feel that in his chest, what can he then do to calm and try to de-escalate himself? And that can be really presented in a structured way, in a visual way maybe, and have that available as a pocket card for him to carry around from location to location, let's say. And again, I'm going to want to try and get some data. Behavior analysts really like to look at data and to see the effect of certain interventions on the behavior. And so, but we can use Brian in this sense, I think. He has a lot of insight. And with trying to get him to think about what's happening before that's making him really stressful or dysregulated, and then what's happening after that you're doing to make that work or not work, and really collect some data to help build that self-awareness in him. And again, that information can then be shared with OT and psych to help put some teaching plans in place, possibly. We know that he does have some rigidity in routines and with preferences. And again, during this more crisis, acute time, we're going to want to try and keep those in place, just like Erin said. What are those really comfort things that should be around him in this moment? And again, assessing that need for sameness. And what happens when those things are changed? I have a feeling we're going to see maybe some escalations, different presentations, because he is going through quite a bit of a transition. And things aren't going to be so structured as what he's used to. And so once he gets settled, we'd be looking at maybe how do we increase that flexibility by pairing, those really high preference things with some a little bit of novelty and introducing that slowly into his space. And again, also talking to him about what are his preferences. Let's get a really good understanding of a preference assessment and those things that really make him tick. And again, the OT and I will likely work pretty closely on that kind of stuff. We have heard that he does have limited life skills and those adaptive skills, as well as the coping and social skills. So again, systematically assessing what are those areas of deficit. Is it the eye contact part? Is it getting people's attention? And really teaching to those areas, those steps within those sequences. And I think for Brian, using what's called like a behavioral skills training model, where you give the instruction, you model it, there's time to rehearse and practice, and then you're giving feedback. That's really discrete and structured. I think will be a really good teaching method for him. And again, being structured and explicit is, I think, the name of the game. And again, however I can help the transition to wherever living arrangements he's going to next. Again, to help make the routines structured and as familiar as possible, I can play that role within the team. And again, deferring to my team to make that a comprehensive plan. Just to highlight some resources that are really good to know about. Surrey Place Center does have the primary care section that does have what's called an ABC, so antecedent behavior consequence template to do some of that behavior tracking, as well as a crisis plan template. And I think what's really neat is an essential information for the emergency department kit. So it's a one-pager, quick, what do you need to know about an individual? And that would be some of the planning we would do once he's settled in case he does need to enter emergency departments across the city. So, yeah, thank you.
Hi, my name's Leora Palace, and I'm a speech-language pathologist at the Red Path Center. And you've all been listening for a long time, so I'm going to try and get right to what the specific language and communication issues are that we would think about and try to address beyond the emergency room and beyond the crisis situation. And I really, in thinking about the traditional speech and language pathologist's role in working with people with ASDs, we tend to think more about speech production, about augmentative communication, and very often miss the more subtle language and communication issues, which may have been part of what landed Brian in the first situation that he was in when he was in university. Kind of being confronted with a traumatic experience and then having to somehow find the words and the means to express what he had gone through and share that would have been very challenging. And it most likely, in addition to everything else, would have been challenging because we know that initiation is a difficulty, and initiation, particularly in language and communication, and predicting and understanding perspective and what the other person needs to know about your experience would be very difficult. So we know that he has a history of this. We know that given his level of functioning, this might never have been addressed, and he may never have received language and communication therapy. And that's certainly something that would need to be looked at and considered from the first traumatic experience that he had. So looking at that, we really need to understand that his emotions and his responses to his emotions were probably learned cognitively rather than intuitively, and the communication that followed and his ability to express his emotions may have been quite significantly impaired, even though he probably had really good language skills. So in looking at him, a lot of what we've been speaking about has been speaking about looking at where he is now as an older adult. But if we could kind of go back in time and look at a young man who was in university, things that might have been protective for him or might have been helpful for him might have included a language and communication assessment, not in terms of speech, not in terms of his sentence structure and his basic output, but rather in terms of how he interacted, how he was able to use language and communication to really connect with people and have meaningful relationships. And the areas that we would look at primarily at that stage of life and at that point in his life would be to look at, is this individual primarily a responder who doesn't initiate but only answers questions? Is he able to maintain topics of conversation and to initiate a range of conversation? We know, given his academic background and his intellectual ability, that he probably was really able to speak well to his areas of interest. But what about speaking to other people or initiating on other topics or being able to follow and maintain some kind of conversation that was other than his particular area of interest? We would also want to look at kind of what are his processing skills like. And we've heard about some of the other sensory areas, but in terms of auditory processing, if he had been in some kind of a traumatic or crisis situation, how would his timing of responses affect his ability to respond in the moment? And that's something that we really need to be aware of. And there might have been a possibility when he was younger, when he was at university, to look at his timing of responses and how his processing could be helped so that he could be more effective in responding. We would also want to look at that age at what kind of interventions could be provided. So we heard earlier this morning about scripting. We heard a little bit about learning to kind of cope in particular situations. But there certainly might have been an opportunity to work on specific skills like reciprocity, like learning more about the social conventions and learning to communicate more effectively in terms of having himself understood and gaining some control in his own life, but also in understanding others so that he could effect some change and some control. So there would be a lot of opportunity to do individual work with him if he was motivated, and then certainly to work with university personnel and staff that could be coached to understand how to support him more effectively, so that there could be some preparation for improved communication for later things that came along, and the more recent one that was described with his mother and that particular crisis. So if we jump ahead and we look at where he is now as a 62-year-old man and look at his language and his communication now and where are we and what can we do to help him now, we need to first of all understand that not only is this an individual with ASD, but that he's a 62-year-old man who has had very limited social contact, who has really been allowed to stay within his circumscribed area of interest and not really have to communicate beyond that. And we know from studies in the typical geriatric population that there's a huge loss and drop-off of language and communication skills just purely by isolation and by lack of opportunity. So seeing him as a 62-year-old man, that would definitely need to be taken into account, that there are communication losses. and increased social isolation and dependence on family. And we would have to determine at that point whether working with him individually is really a realistic goal, depending on his level of motivation, depending on what his future and what his outlook is like if he were to retire. And then there would most definitely need to be indirect involvement, again, through consultation or coaching, depending on where he ends up living and who is around him and supporting him. So I think I'm kind of lost on the panel here today, but very often language and communication is overlooked when there aren't obvious speech and language deficits. And I think it's a very key, we know it's a very key piece to diagnosis, but I think it's also a key part of the treatment and the assessment of what can we do to support an individual and look at quality of life and look at giving them a fuller experience and ability to have control in their own lives.
So I'm going to tell you what it's like to be a mother who has a team like this, plus coordinating the care. So I let you know that Ryan had a traumatic brain injury. And I also let you know that he had had multiple mild traumatic brain injuries before the biggie, and that as a family we had been dealing with the minor ones and had a whole lot more experience in dealing with brain injuries and insults to the brain. So when Ryan came out of the intensive care unit, the neuro ICU, to the neural trauma unit, every solitary sensor issue that we had been trained as a family to deal with and reduce was escalated on that nursing unit. So the fluorescent lights were beaming in his eyes. There was a clock that didn't work that drove him nuts. Nurses were bothering him every hour, taking his vital signs, and there were different people that came in. He was injured on a long weekend, and on the Tuesday, when he was starting to be reduced in terms of his drug-induced coma, every solitary discipline that needed to look after him was in that day. So he had no rest whatsoever. The boy that ended up beside him was vomiting all the time, and the bells were ringing and nobody was answering it. And Ryan perceived that I had put him into an alternative universe. He felt that I had put him into the worst hospital with the worst nurses ever, and it was all my fault, and he was kicking me and hitting me and totally out of control. And this is my baby boy. It was very, very difficult. I knew that he had a brain injury. I knew that as a professional where he might have ended up as a result of this injury. He was smart enough to blow out his ear, so a lot of the blood had drained and he didn't need OR. But I'm left with this kid who was, as I said before, a golden boy, and I'm facing what he may end up being. We were very fortunate in that we were adopted by an acquired brain injury program at the Hamilton Health Science Center, and mostly because I had just moved to the Ontario Psychological Association. I think if I had stayed at the Ontario College of Family Physicians, I would have been much more reliant on the medical community. But I ended up in an environment where team-based care was the norm. We brought Ryan home within a week of his injury. And my occupational environment was such that they gave me permission to work from home. And I had a daughter who was able to help out, and a family that took time off work so that when I did have to be at meetings and the like, they could fill in for me. So we were the ideal family to be able to deal with the issues. But we also had this incredible team. And there's 2 members of the team that were added as Ryan continued to progress. And some of the team members worked with me in order for my behaviors to be supported as well. So I wasn't triggering him. And I mentioned the injury that he had that really affected his ability to control some of his aggressiveness and assaultive behaviors. So a behavioral therapist not only worked with Ryan, but worked with me in order so that I was able to better support him and didn't trigger him. Because I was the one that he trusted the most to behave the worst because he knew I would always love him. That was the message that was being delivered. He had physical injuries, so he needed a lot of physio OT. So that was added to the team. And as he progressed, we were heading towards getting him back into university. And the speech-language pathologist role became one of really helping him to focus and plan on how he was going to cope with his work. Neuropsychology really helped us to understand how his brain was working so that the rest of the team could really function. And he really needed a recreational therapist to get him out of the house and back into an environment where he could actually get out of the house and be comfortable. So going to the shopping center was a big deal for him. He was imploded with sounds at the mall. He could pick up on everybody's conversations, but the one he should be concentrating on, and he would get so upset. He had sensory problems, so smells bothered him. It was difficult for him to settle to sleep because it was too hot, and we would wake up in the morning, and he would, in the winter, have the air conditioning down to 60. We suffered, but he was comfortable. And we had, as a family, to really learn how to make sure that we knew all the appointments that were being made by every one of the team members, and that somehow they weren't so overwhelmingly anxious to be with him and do what they do, so that it didn't end up every day with 5 and 6 different people coming in, but spread out. So my job became one of a case manager, as it were, in making sure, number one, we didn't forget meetings, and number two, that we organized them better. And that at least once every month or two, the whole team came together with us in order to really talk about next steps and what we needed to do in order to move him forward. We went through a phase of, thank God he's alive, and he's in university, and look how good he's doing. This is amazing. How did we get him within 3 months to start taking courses? And we as a team got through 2 courses with him from January to March of 2014. And the injury had happened in August of 2013. We, as a team, got an A+ and a B- on those 2 courses. And we, as a team, were so proud. But then as parents, you go through a phase of, as I said before, he's not the boy that he was, and he's not the boy that he would have been. And there's a sense of grieving. There's also this sense of who he is now is so amazing because of all that has been put into him. This morning, there was a word that meant a great deal to me on one of the slides from the presenter, and it talked about support and supporters. That word meaning champions, meaning those that are so involved in trying to make that young man the best that they can be, is what that word meant to me. And as a parent, Brian and I could not have gotten to the point that we're at without each one of the team members being able to contribute without getting to a point where the team was so disturbing, as it were, in terms of how we needed as a family to live our lives. So they were incredible in making sure that they were always there when we needed them, consistently working towards a goal of making Ryan the best that he could be, but helping us to be a family, to go through the steps of grieving that you will see within any of the family members when they're dealing with someone who has a disability, labeled autism, labeled a developmental disorder, or labeled, as Ryan is, with an acquired brain injury. So in my role at the Ontario Psychological Association, I've been dealing this week with a family. So the woman had a very traumatic delivery, and the child is very, very severely compromised with CP. She has 2 other children that she feels she is terribly neglecting, because the child is now 18 months and has required 24/7. She's exhausted. Her marriage is breaking down, and she's at the end of her ropes. And if you listen to the story of autism, the system doesn't always help us the way that it needs to at any stage of one's life when one is dealing as a family with those that are finding themselves compromised. So this particular story is very important to me for the interprofessional messaging that we can deliver as individual professionals and as members of the health system in this province. We have an opportunity to do such great advocacy work to make things better for the people that we serve. But we can also, on our own, make sure that locally we bring together the right people at the right time and forget about the barriers of funding, the barriers of organizational structure. Just make sure that every person has what this team would be able to deliver to Brian. And that's my personal patient-mother relationship message to all of you. And I'd really like to open it up to questions from each of you to the panel. And we, as a panel, would really like to hear from you some of your experiences in trying to pull together interprofessional teams or in your personal lives as professionals of dealing with situations like Brian and through his lifespan. Thank you.
on? When I worked in the emergency department, one of the crucial things was to establish a good relationship with our security department. And we really worked as a team. So, I mean, who's kidding who? We all tend to get to know each other. We socialize together, and you learn who's strong at what. Before we did anything, we informally, through the nature of our relationship with each other, would talk about what we were going to do. So here's what's going on with this guy. He's scared to death. So I'll go in and talk, but I want you far away. Just sometimes I would ask security to wait outside the room while I went in, so I could go in and say, listen, we've got to get, we want to help you get your behavior under control. I'm kind of stuck here in the emerge, and I've got to do this. I'm giving you a chance, like we can do some deep breathing together. We can do some stuff together, but look outside the window. And these guys aren't going to come in right now, but let's see if we can calm you down first. And so we'll make a plan like that, and the plan is made with security based on the individual situation at the time, based on that person. Some people become a little intimidated and will calm down because they don't want medication or that sort of thing. Other people will test limits. So I can't really give you a pat answer. You're flying from the seat of your pants based on the situation at hand. And one thing that we all agree on is to provide the least intrusive method possible. So a lot of it is really built up on the relationship that you develop with the person. I couldn't hear the entire question, so I don't know if I answered the entire question. Yeah, okay, thanks.
One of the things that I'd also emphasize, there's been a lot of talk about putting the patient in a quiet room. When we've been designing emerge departments or family practices, we have made sure that the room in which we put any patient who has the potential for violence in an arena where the rest of the team can get to them very, very quickly. Oftentimes you'll find the quiet rooms in another part of the emerge department and very hidden. So architecturally, you can do a lot to make sure that the facilities make it safe for staff to be in an environment where things may go awry.
Actually, can I address that too?
Yeah.
When I worked in emergency, we weren't that fortunate, despite the fact, I mean, in a perfect world, I think that exists. But I remember our quiet room was also used as a bereavement room, was used where the room where police would come in and bring people. And we called it the quiet room, and it was anything but quiet. So we also had to deal with the situation at hand, and you have to have a good working relationship with the rest of emergency, who can also maneuver people around so that you have that quiet area if you don't have it in your emergency department. But thankfully now they're building a new emergency department that should allow for that. But it didn't happen for many, many years, just on a realistic basis.
Hi, my name is Mike. I'm a frontline autism specialist worker. Everything that you guys said today resonates so coincidentally with something that's been going on in the past month with somebody that I support, who's currently actually at CAMH. And so to hear, it's almost serendipitous, I guess is the word. I don't know. His father died a year ago of cancer, and his mother just died of a heart attack 2 weeks ago. And he just had nothing and sort of thrown into this void because they didn't make proper arrangements for him in his life. So for me as a worker, I had to go to the police station. I had to advocate for him in a lot of ways, and it was a very difficult process for me to go through all this. I've known this family for 3 years, and so for me personally to hear exactly the process of how that I didn't know any of sort of what he would be going through, some of the steps that he might have gone through, and maybe still going through at CAMH. I just want to get more reassurance, I guess, that he is indeed getting all of these supports from a place like CAMH that he would be at, that he's currently living at right now, because it's just an incredible coincidence that everything you're describing is so similar to his life and his circumstances. And And I just want to thank everybody for all the work you guys do. It's amazing. And I just want to get a little bit of reassurance that he is indeed getting each of these specific things, because I'm not sure that he is. Like, one of our workers went in the other day and he hadn't, his gums were, he hadn't brushed his teeth. He had really bad breath. So the worker that works with my agency said, I'm going to brush your teeth. And they did, and his gums were bleeding. And so they asked the nurse on call about it, and they didn't know anything about it. So I get a little bit concerned as an advocate, I guess, just to make sure that he's being cared for as best as possible. And you guys sound like you're doing a fantastic job, and I just want to get some reassurance about that stuff.
Zero.
I wish we had a KMH person answering that.
I think the
it's hard for us to say because we can't first provide the reassurance not knowing the case in that very specific case. But I think having heard this presentation, you're even better equipped now as an advocate to be able to kind of check with your notes, check with what you heard today, and just trying to make sure that all of those pieces are fitting together, because we have described an ideal world and an ideal situation, and these things don't always play out the way we've described they should. So as an advocate, I think you're in a great position now to go back and just make sure. Yeah, no problem.
So I just wanted to add to that. So just in terms of him getting the proper support that you feel that he needs, you should try and connect with a social worker that is on that unit to make sure that she's hearing your needs and your concerns for the client, and trying to get those supports in place if they're not already in place for him, so he has the best care that he needs.
And just another thing, just with lots of different professionals involved, it's again back to that first question about communication within the team, is rallying the team, pulling the different providers if you can, even though if they are from all the same agency, just to get a clear picture of what the current plans are for this individual and the next steps, let's say, as well.
So I'll make 2 points. Number one, when Ryan was 10 years old, he was the ring bearer of my daughter who was getting married. And Ryan was very teary that day. He came up the aisle crying, and he cried for about 2 hours. And it took him probably 2 days to tell us why he was upset. And he said that every one of the people that he really loves left home. So as each one of my other children left, he was the only one left at home. And he said, you and Papa are old, and you're going to die and leave me too. So he made us make sure that we had a guardian for him if anything happened to us. We had to show him the will that gave him assurance of both funding as well as a guardian. So we did all of that, and everything that we could have done, it was because Ryan pushed us. But I think if you go onto the ministry's website and you look at Patient First Action Plan, in which they're really trying to move towards a much more sub-LIN level at the primary care level in the communities that brings the right people together for individual patients to deliver the kind of care that you're hearing from this team, and go into it and answer the survey and let the government know the kind of cases that you're dealing with and how that patient-first model would really help, and what you need as individual professionals in order to make it happen in your arena. So I think having people in hospital is probably not the model in which this type of professional team coming together is going to happen. It's going to happen because we make our communities work the way that people require it. Forget the barriers of various teams or people working for organizations, but how do we bridge organizational structures to bring the right people together at the right time? Ryan was lucky in that the acquired brain injury did it for him, but we have an obligation to make sure that the right people come together in helping when and where people need it. So down in the States, the behavioral home model is what they're talking about. So Google behavioral home, and you'll see a model of for mental health issues that really look at the kind of models we have in place down in the States because of the movement from a funding perspective to medical home, and then bringing the right team members together, and they're calling it behavioral homes, but within the primary care arena. Okay? So none of the barriers of organizations, but.
That's great, thank you. What was the name of that website that you said was distributed?
So it's the Ministry of Health website, and it's the Patient First Action Plan. So this is the transformation that our current minister is trying to implement. And hopefully in 3 years, the kind of cases that we've been discussing, so an individual at 2 years of age being diagnosed and what a family goes through, when Brian is going through school and he's being bullied, how do we bring the right team together in the school system in order to help? When he gets to college and university, what are the accommodations that our universities are able to provide for him? And now that he's in the workplace, what accommodations do we have for workplace mental health? And then that stage where those that have got developmental disorders are losing the structures that families provide. There's questions at the back.
Just following on here about the security, and I mean, in terms of best practices, definitely work with your security to educate them, to make sure that they know what to do. But stepping back from that, you avoid situations of crisis by providing maintaining best practices of things like a quiet, stress-free area where the individual with autism can go when they need to. Because that comes up a lot. Things are very, very overwhelming in a post-secondary institution, and I believe that's what you're referring to. And
That can happen in
I
any.
see that lacking in our post-secondary institutions. You know, people go, oh, they go to the, as you guys were saying, they go to the counseling office, and it's like chaos there. It's not the place to go for that quiet, stress-free, sensory-friendly area. I know the two pilot projects are attempting their own replication of those kind of quiet areas for individuals with autism, but that helps to prevent that crisis.
Okay, we'll take one more question, and then we're due to go down for lunch.
Question about social worker. So at what time do you determine that your services are no longer needed? And do you like pass the individual over to a caseload with the CCAC or with the LIN? Just curious as to, because I've been hearing that like sometimes the individual like once the service is done, do you come back into it if it's needed for the individual, or is it passed on to somebody else? Just curious.
So I have had the opportunity both to work in the hospital setting as well as an outpatient setting on a consultative basis. So in the hospital setting, once a person comes into the unit, is on the unit, I do more of the coordinating case manager role in terms of providing resources, getting the resources that the individual will need discharged from the hospital. So I coordinate service, do the transitional piece, and I pass it on to the supports in the community, whether that be a community social worker or a case manager, or if the family's taking the lead role in the coordination for that individual. On an outpatient setting in the community on a consultative basis, the role that the social worker plays is to liaison with the community supports and strengthen them in terms of what the individual does need based on the assessments that they have come through the CAMH service, which is on a consultative model, and providing recommendations not only to the community but the family in terms of how they can best support the individual and take care of themselves as well. So that would be in the discharge plan. So are you a social worker as well? No. Oh. Yeah. Yeah. So for social workers, mainly in the hospital setting, you always start with a discharge plan. So We know that hospital is not the best setting for individuals with ASD. It's in the community and them receiving that treatment and that support within the community. So we always plan for the best supports for the individual within the community.
And what you often find is they simply get told to go see their family doctor. Okay. Well, I hope you enjoyed the presentation and that you have a great lunch. And I know you'll enjoy listening to Christine Elliott, who will be our patient advocate, the very first one. And so someone that we need to keep on top of with the patients who have autism spectrum disorder. She needs to hear from you. Thank you.